Hello, welcome everyone. Today we begin this chapter to understand the intricate balance of fluids in the body and its derangement leading to causation of edema. Now, all of you know that our internal environment inside the body consists of more of water than of the solid weight. The water inside the body comprises 60% of body weight, and this 60% body weight is present in two broad compartments known as intracellular fluid compartment and extracellular fluid compartment. The intracellular fluid compartment is the one in which the fluid is present inside the cell, and whatever is present outside the cell, we label it as extracellular fluid compartment. Now, this compartment is further subdivided into interstitial fluid, including lymph fluid, which makes up 12%, then intravascular fluid or blood plasma, which makes up 5%. That means the blood which is flowing in the vessels, it just constitutes 5%. Here I would stop and try to make you understand that if a person weighs 80 kgs and 5% of the 80 kg is just 4 kg, which means that it's the 4 liter blood which is circulating inside, 4 liter of the fluid is present in the blood which is circulating in the vessels. Then we have got mesenchymal tissues, the stromal tissue, etc., or the connective tissue which hold up water, and transcellular fluids which is moving between the cells. So here is a diagrammatic represent that intracellular fluid compartment. It is larger than the extracellular fluid compartment, and out of this, the majority of the extracellular fluid is present in the interstitial spaces between the cells and the lymph. Then it is present in the vessels, circulating in the vessels, then in the mesenchymal tissue, and very small amount in the transcellular fluid. Going further, here we have got a tissue in which cells are present, and this tissue is in touch with a vessel through which the blood is flowing here from the arterial ends towards the venous end. So the water which is present inside the cells, inside these cells, that's the intracellular compartment, while the extracellular compartment would include the water which is present in this whole area in between the cells and in the tissue, which we call as the interstitial part, and that which is flowing through the vessels, which is called as intravascular part. Now, the water which is present in this area and in this area, and for the sake of discussion, let's call it fluid, which is present inside the cell and outside the cell in the interstitial spaces, does not have the same composition. There is a very definite difference between this composition. First of all, you have to understand, if you remember from your physiology, that the cell membrane is a semi-permeable membrane, and there is flow of fluid within and outside this. It is in a continuously the fluid and the particles, they are going in and they are going out in a very well behaved, regulated and controlled manner. It's not ki just unki marji, as they want they can do it. No, they are flowing in a very regulated manner. So what is present here and what is present here is not same. So if we talk about cations, the main cations or the ions with the positive charge, sodium and calcium, are present more in the interstitial fluid, while inside the cell, the main cations are potassium and magnesium. Same way, the main anions which are present in the interstitial fluid, they are chloride and bicarbonate, while those which are present inside the cell, they are phosphate. Now, presence of these cations and anions which are outside and inside, they are able to freely mingle via the semi-permeable membrane of the cell. So, but they are still controlled to remain in their area, and this tussle always keeps on going. So to bring a potassium which comes outside or the sodium which goes outside, it will ultimately be brought back to its original state actively with the other cell by something called as sodium potassium ATP pump. You can know more about this pump by clicking on this link over here. Now, for the water to move inside the cell or for it to move outside the cell, it will require some pressure. It will require some change in the pressure, and it will move in the direction of higher pressure to the lower pressure. That pressure is called as hydrostatic pressure. Now, to explain you the concept of that pressure, let's see, look at the next slide, the diagram over here. You see, if we have a YouTube, and in the YouTube, at its U part, there is a semi-permeable membrane, and the water is present in both the limbs. Now, this water can freely go from this side to this side, or this side via this semi-permeable membrane. It allows the movement of water to go here and there freely. So, what is going to happen? If we do nothing, the level of water in the limb A and level of water in the limb B is always going to be the same. This is the physics from your classroom. If I have to move the water from one limb more to the other limb, I will have to exert some pressure. Let's say I want the water to move in this direction towards the limb A. What will I have to do? I will have to exert pressure on limb B. If I exert this pressure in this direction, that water will, here it will come down and here it will move up. So if I apply the pressure, let's say I apply the pressure of 10 millimeter of mercury, what is going to happen? The level of water in the limb A will rise, while that in the limb B. What I have done, I have made water to move from limb B into the limb A by applying some external pressure. Now, this application of the external pressure, which makes the water move from B to A, is called as hydrostatic pressure. So, by applying 10 mm of mercury of pressure, I have made the water to move into the limb A. Now, can there be any other way by which I can move water into limb A without applying that pressure, without applying that external pressure? Is it possible? Yes, it is quite possible. If I add solid particles, or we call them as solutes, if I add these solid particles in the limb A, these particles have to be large enough that they cannot cross this semi-permeable membrane. Now, what is happening? The concentration in this limb has increased, while in this there is no solid particle. So, what will happen is that by doing this, I can make the water to move from limb B into the limb A by the same amount by which I was applying that external pressure of 10 mm of mercury. So I can apply the similar pressure via addition of the solute or via increasing the concentration of the fluid to make the water flow in that direction. This is a pressure which is equivalent to that hydrostatic pressure, and we call this as oncotic pressure. So now we have got two pressures. One is hydrostatic pressure, which was applied from the top or from outside, and then another we have got oncotic pressure, which depends upon the presence of solid particulate matter inside the fluid, increasing its concentration. By these two pressure, I can make the water go in any direction, and that's what happens in the nature. Now here is a small example of a tissue which is innervated by the, which is in which from the artery blood is flowing going into the arterioles and these capillaries, these are intricately present inside the tissue, and the blood is being collected in the venules and going into the vein. So here the blood which is coming in the arteriole, it is a oxygenated blood. It carries the nutrition which are from the metabolic and products of the liver, etc. It is carrying. From here the blood comes out, moves into the tissue, take the oxygen and nutrients to the cell, and as the blood flows in this direction, all those waste materials which have been generated by the cells and the carbon dioxide which is released by the cell, now the blood will be carrying that blood will come into the vein, and from that vein it will take it to the heart. Again heart will send the blood to the lungs. In the lungs again it will carry the oxygen, and then come back to the heart, and then heart will again send the blood over here. How this very fine thing continues in the nature. Now let's talk about that. We have already understood the concept of hydrostatic pressure and the oncotic pressure. Now if I have to diagrammatically represent only this much part of the tissue, then it would be something like this. I have got the tissue. In that tissue there are present cells, and that tissue, blood is flowing in the vessel. This is a capillary. This capillaries, remember, these capillaries have got very small gaps in them, so they are thus, you can say, semi-permeable membrane. So arterial and oxygenated blood is coming from this end, and as it is flowing towards this blood is becoming deoxygenated, and then it goes out into the vein. From the vein it will go into the heart. This is the venous end. Now let's talk about those pressures, how this blood, the fluid in the blood, moves in and out of this vessel into the tissue and etc. So how that happens? First of all, let's talk about the hydrostatic pressure which is acting on the blood which is flowing in this vessel. On the arterial end, there is a pressure which is generated on the one. Remember that picture of the piston by which I was pressing it from the top to generate the pressure? Same way over here, the heart is pumping the blood, and by its contractibility, it is putting a pressure on the blood to move forward. Now that pressure which is on the arteriolar end, it is 32 mm of mercury. That 32 mm of mercury is pushing the blood into the vessel, and since this pressure is reflected on the walls of the vessel, the blood will try to come out, sorry, the fluid or the water in the blood will try to come out with a pressure of 32 mm. Good. At the same time, on the venous end, as it reaches further away from the heart, that pressure drops. By the time the blood is flowing on this end, that pressure decreases to just 12 mm of mercury. So you see, hydrostatic pressure is always more on the arterial end while it is low on the venous end. On the arterial end, we have a hydrostatic pressure of 32 mm, while on the venous end, we have a hydrostatic pressure just of the 12 mm. Now, this is a great difference. That means the blood will try to come out of the vessels with more force, higher force at the arterial end, while on the venous end, it will try to come out only with a 12 mm. Now, this interstitial space, since the tissue, blood is present in this tissue, or the fluid is present in this tissue also exerts certain amount of pressure on the blood. I mean, the blood is coming from the 32 mm of on this side. It will be resisted by the tissue by 4 mm of mercury. So by 4 mm, this tissue will resist this blood to come in, because whenever the blood, it is not going into an empty space or in a vacuum. It is going into a already fluid filled space. So that fluid filled space will try to resist this. Although that resistance will be very minor, but still it is a resistance. So here it will resist it with a 4 mm. And since it has got nothing to do with the heart, it has just got to do with the presence of fluid in the vessels. On this end also, it will resist it with a 4 mm. So what does that mean? That the hydrostatic pressure on the arterial end makes the blood flow from the capillaries into the tissue with a net effective pressure of 28 mm, while that pressure drops drastically and just remains 8 mm off. So hydrostatic pressure will always push the blood out of the capillaries, but mind you, on the arterial end, it will push it with 28 mm of mercury, while on the venous end, it will push it with 8 mm of mercury. So here we have got a drastic drop in the pressure. I hope this much part is clear to you. Now, going further, let's talk about the oncotic pressure. Now, since the plasma in the blood contains proteins, particularly albumin, that is a large molecule and acts as a solid particulate. It increases the osmotic pressure. It will try to suck in the fluid from the tissue. With how much pressure? With 25 mm of mercury. So, with 25 mm of pressure, the oncotic pressure, the presence of protein in the capillaries, they will try to bring the fluid inside. And same way on the venous end, the pressure will, because the protein will remain the same, since they had not been able to escape out into the tissue because their size is larger than the gaps of these capillaries. They flow towards here, and over here same amount of proteins will remain. So both on the arterial end and the venous end, it will try to bring the blood, or sorry, bring the fluid back into the capillaries with 25 mm of mercury. There is no drop. Hydrostatic pressure will try to push out and it will reduce on the venous end, but oncotic pressure will remain both same on the arterial and the venous end. Now, how the tissue will counter? Okay, the tissue also has got particles in it. It also has got crystals in it, crystals and crystalloids in it. They will try to, they will also try to take the blood fluid into them. So that is about 8 mm. So the crystalloids in the tissue will exert a oncotic pressure of 8 mm, which will move the fluid into the direction. And same way, it will be a 8 mm on this side also. So what is going to happen? What happens is that with the 17 mm of pressure, the fluid will try to come out from the tissue into the capillaries. So now we have got four counterbalancing forces: this 28 mm, 17 mm, this 8 mm, and this 17 mm. So what does this mean? This means that with the net 11 mm of pressure, the blood is moving into the tissue on the arteriolar end, and with the net 9 mm of pressure, the blood is moving out from the tissue towards the venous end. I hope this much picture is clear to you. So the blood is going inside the tissue on the capillary end with the 11 mm of mercury. Why? Because the hydrostatic pressure is 28 mm pushing it, while oncotic pressure is 17 mm trying to take it back. The blood is coming out of the tissue into the vessel with a 9 mm of pressure. Why? Because the hydrostatic pressure is 8 mm while it is contracted by 17 mm of pressure towards the vessel. So that this goes on. Now, this pressure of 9 mm is definitely less than this pressure of 11 mm. There is still a difference of 2 mm. That means the amount of water which had gone out, whole of it is not be able to come back. That difference of 2 mm, that is handled by the lymphatics. So it will be drained away in the lymphatics. So you see the beauty of the nature, how it makes the fluid moves in and out of the tissue, and the circulation keeps on going, and difference is handled by the lymphatics. So in this manner, the life goes on. So here you see in this slide, the blood is coming in, the fluid carrying oxygen and nutrients is going inside on the arterial end. It collects the waste material, carbon dioxide, etc., from the cells and goes back into the vessels to go towards the heart, and some amount of the fluid that is handled by the lymphatic. This continues on and on and on, and it maintains the perfect balance, the shape, and the balance between the internal environment. Now, if any of these pressures get deranged because of any reason, that is leads to accumulation of fluid in the tissue, which we call as edema. So how that happens? Now let's see that. So whenever there is disturbance of body fluids and electrolytes, that would lead to upset in the fine balance between these hydrostatic and oncotic pressures, and that would lead to conditions like edema, overhydration, and dehydration. So let's begin with edema. What is edema? Edema is a Greek word derived from oedema, which means swelling. So edema is abnormal or excessive accumulation of fluid in the interstitial spaces. So it is abnormal and it is excessive. Now, when this abnormal or excessive fluid accumulates in the body cavities, then we label it as effusion. Effusion is also a type of edema because it is accumulation of the fluid, but it occurs in the serous cavities of the body. So we have cavities like pleural cavity, a cavity which is around the lungs. We have got pericardial cavity, and we have got peritoneal cavity. If the fluid accumulates in this area, then we call it as effusion. Now, peritoneal effusion is also labeled as ascites. Now, ascites is a special word used for the collection of fluid in the peritoneal cavity. And finally, we have got another term which is called as anasarca. It is abnormal or excessive accumulation of fluid in whole of the body. So when the fluid accumulates in whole of the body, so edema could be localized, but when it is generalized and the fluid accumulates in whole of the body, then it is called as anasarca. So these are the few terms which are related to edema. Now, what causes edema? We can broadly classify 6 patterns in which the edema occurs in the body, and all these patterns upset the fine balance between the hydrostatic and oncotic pressure, causing the entry and exit of fluid in the tissue. So These are decreased plasma oncotic pressure, increased capillary hydrostatic pressure, lymphatic obstruction, tissue factor, increased capillary permeability, and sodium and water retention. So let's begin with the first one, decreased plasma oncotic pressure. Now what happens? This here was the diagram which I had explained to you, that the fluid is going with a pressure of 11 mm at the arterial end inside the tissue and coming with a pressure of 9 mm at the venous end out of the tissue, and this difference of 2 mm is handled by the lymphatics. This is what normally happens. But when there is decreased plasma oncotic pressure, now this over here, which was earlier 25 mm, now becomes 20 mm on the both the sides. Why this could happen? Any of the reasons, I will be taking up the reasons later when I will be discussing the conditions in which this happens. But here you have to understand that this decrease of oncotic pressure in the plasma from 25 to 20, it upsets the balance. Now earlier when the fluid was going here with the 11 mm, now it is going in by 16 mm, and when it was coming out by 9 mm, now it is coming out by just 4 mm. So that is creating a difference of 12 mm, which cannot be handled by the lymphatics properly. So what is going to happen? That more fluid is going to remain in the interstitial spaces, and that would lead to edema. So that is the mechanism of plasma oncotic pressure decrease causing edema. Now, second one, we have got increased capillary hydrostatic pressure. Now here over, see that earlier when there was a 28 mm of pressure, hydrostatic pressure pushing the fluid inside, now it has increased to 35 mm. At the same time, on the venous end earlier, where there was a pressure of 12 mm pushing the fluid in, now it has become 15 mm. So overall, there is a more pressure both at the arterial end and both at the venous end, causing the fluid to move more into the tissue. So here, when there was 11 mm, now it is 14 mm with the more pressure fluid is going out, and just 6 mm it is coming out, creating a difference of 8 mm, which is again more than 2 mm, which cannot be handled completely by the lymphatics. So there is a edema in the tissue. Then we have got lymphatic obstructions. If due to any reason lymphatics are not able to handle that 2 mm difference of the pressure, that is going to retain inside the tissue, and that would lead to edema or abnormal collection of the fluid. So nothing special about that. Then we have got something called as tissue factor. Now there are certain tissues which are loose, and since they are loose, they don't exert that 4 mm of hydrostatic pressure. Instead, they just exert 2 mm of hydrostatic pressure. Now due to less exertion of the hydrostatic pressure, to counter the hydrostatic pressure of the plasma, there is a slight difference in the fluid movement. Instead of 11 mm, fluid goes in by 13 mm, and instead of 9 mm, fluid comes out by 7 mm, which creates a difference of 6 mm. Now these loose tissues, like in the scrotal region, like around the eye, periorbital regions, so with the low hydrostatic pressure, these areas, they are more prone to edema. Also, this can occur in a condition where there could be increased gap and more protein move into the interstitial fluid. And then what is going to happen? The plasma oncotic pressure of the interstitial fluid is going to increase in that tissue. That will also be the same reason for the edema. That is discussed in the fifth point, another point of the increased capillary hydrostatic pressure. Let's come to it. So here, if there is increased capillary permeability, what is going to happen? The protein which was present inside the plasma is now going to move inside the tissue. That big molecule which cannot earlier go, because these holes between these cells or the endothelial gaps, this was small. But if these endothelial gaps increase in size, now these large protein molecules, they will escape in the interstitial region. Just imagine what is going to happen. First of all, here the protein will decrease, so the plasma oncotic pressure will decrease. So see what happened here. The plasma oncotic pressure, which was earlier 25, now it is just 21. Secondly, the plasma oncotic pressure, because the proteins now have come on this side, so the plasma oncotic pressure of the interstitial is going to increase. So here earlier where it was just 8, now it is 12. Now that is creating a higher difference. Same way over here it is happening. So now what happens? The fluid which was earlier moving with just 11 mm of pressure is now moving with 19 mm of pressure, and which was coming out with a 9 mm of pressure is now just coming out with 1 mm of pressure. That makes a huge difference, and so lymphatic channel, and that's why increased capillary permeability is responsible for a heavy edema. Usually this happens in the localized region during the inflammatory conditions, but you see in inflammatory conditions overnight there is a huge swelling in that area, so that is responsible for the edema. And finally we have got sodium and water retention, which I will take up in explaining the renal mechanism of sodium and water retention. Now let's come to pathogenesis of edema. Let's discuss the condition. So we have discussed how hydrostatic pressure and oncotic pressure, they play a fine balance, but if that is disturbed, which can lead to edema. Then we talked about the 6 ways in which that could be disturbed. Now let's talk about the conditions which cause those disturbances. So decreased plasma oncotic pressure, which was responsible for edema, is caused due to condition known as hyperproteinemia. It's a condition in which plasma protein levels decrease. Normal plasma protein levels are more than 5 gram per deciliter, and they can go up to 8.5 gram per deciliter. But if any condition leads to hyperproteinemia where the level decreases below 5 gram, we call that as hypoproteinemia. Now, this hyperproteinemia can occur because of uh, renal diseases. You see, kidneys are responsible for filtering the waste from a body. At the same time, they are also responsible for retaining the important particulates, the nutrition, etc. That is not supposed to be filtered, while waste is to be filtered and it has to be sent out in the urine. If there is any renal disease, an important molecule like protein, which was supposed to remain in the body, starts leaking out in the urine, just imagine what is going to happen. Over the time, too much of protein will leak in the urine and it will remain less in the body. So that will lead to hyperproteinemia. This condition is called as nephrotic syndrome. Then we have got another condition, acute glomerulonephritis, that can also in the same way cause leakage of protein in the urine and lead to edema. Another reason, important reason, which can cause hyperproteinemia is cirrhosis. This cirrhosis is a condition in which the liver fails. It's a cause as end stage hepatic disease. Uh, Here, the liver totally stops its function. It becomes totally fibrosed and damaged, and it stops its metabolic function. Now, all of us know that proteins are synthesized in the liver. They are metabolized in the liver. They are synthesized in the liver from fats and uh, carbohydrates, except for essential amino acids. All the amino acids, they are synthesized in the liver. Now, if the liver is damaged due to any reason, that synthesis of the protein stops, and that leads to hyperproteinemia. Now, this hyperproteinemia will cause edema by collection of fluid in the peritoneal spaces, and then it is called as ascites. Remember, I told you ascites is collection of fluid in the peritoneal cavity. So here we have got a patient with the ascites. You see how this abdomen is swollen. That is because of the collection of fluid in the peritoneal cavity, and that is because of the cirrhosis. One very common condition which can cause this liver damage is alcoholism. So that alcoholism causes damage to the liver, it leads to cirrhosis, and that cirrhotic patient cannot synthesize protein, and that leads to hyperproteinemia, and that causes to decrease plasma oncotic pressure, and that leads to collection of fluid in the peritoneal cavity. So this is a straight connection between how the fluid accumulates in the peritoneal cavity. Then there is a condition known as kwashiorkor. It is seen in poor countries where the kids, they are not able to have sufficient proteins in their diet. So that leads to severe malnutrition, and that malnutrition is protein specific malnutrition. In such a condition also, the child does not have sufficient protein in its body to maintain the plasma oncotic pressure, and whole of the body of the child gets bloated, and that condition is called as anasarca. Remember, I told you that generalized edema leads to anasarca. Generalized edema, sorry, it does not lead to anasarca. Generalized edema is also known as anasarca. Now, then there is condition called as protein losing enteropathy. Here what happens, that too much of mucus is produced in the intestine, and that is lost in the uh, feces. This mucus is protein rich, and this excessive loss of protein in the feces leads to decreased plasma oncotic pressure. So here this was the diagram. I am not going again to explain this diagram. Only the thing is that the difference which was of 2 mm now has become 12 mm. Next condition is increased capillary hydrostatic pressure. It is caused by especially by the abnormalities of the heart or cardiac diseases. So there is condition called as congestive cardiac failure. In congestive cardiac failure, what happens? The heart left ventricular failure occurs. The left heart feels pumping the blood outside, and since the blood cannot go further, the blood which is coming via the pulmonary arteries, that creates a backlog pressure, and that pressure is reflected in the lungs, and the person has got pulmonary edema. Same way, constrictive pericarditis, the heart is not able to fill in completely, and so the blood which is coming through the pulmonary arteries, back pressure is exerted on it. That pressure is reflected in the pulmonary capillaries, and from those capillaries, blood starts oozing out. Similarly, in ascites of liver disease, previously we said that in the cirrhosis, what happens that liver is not able to synthesize protein, but also another thing happens in the cirrhosis, that liver gets its blood from the portal vein, and that portal vein is formed by the blood which is coming from the uh, stomach, blood which is coming from the spleen, and blood which is coming from the intestine. So it collects the blood into the portal vein and it goes into the liver. Now what happens in the liver diseases, this blood cannot move further into the inferior vena cava. So in the portal area there is a back pressure. So hydrostatic pressure increases in all the capillaries of the stomach, of the spleen, of the intestine, and because of that increase in hydrostatic pressure, there is collection of fluid in the peritoneal cavity, which we call as ascites. Now this is also called as portal hypertension. So what I have explained to you is just portal hypertension. Then we have got passive congestion like venous thrombosis, in or if there is some thrombus in the vein or the vein is blocked, again the pressure will be reflected in backward into the capillaries. Same way, if pregnant uterus or there is a tumor which can be pressing on the inferior vena cava, that will uh, decrease the return of the blood to the heart, and so there is edema in the lower limbs of such a person. Then we have got postural edema. In postural edema, what happens if the person is standing for too long, for too long, the blood which accumulates in the feet. Now, due to gravity, this blood will exert more hydrostatic pressure on the capillaries of that, and that's why people who keep on standing for a long time, they have got the edema in their feet. Their feet become swollen. So that is due to increased hydrostatic pressure. So these are the causes which cause increased capillary hydrostatic pressure. Here we have got again the diagram. I will again not go into the details, only see that there is this difference. It increases from 2 mm to 8 mm because of the increased hydrostatic pressure in these two areas, arterial and the venous area, and that is responsible for edema. Now, lymphatic obstruction, this can occur in condition like if for any reason lymph nodes are removed. And why are these lymph nodes removed? For example, if somebody has got a breast cancer, then there is an operation performed as mastectomy. Here, whole of the breast is removed, and this cancer could metastasize into the surrounding lymph nodes, and the nearest lymph nodes are the axillary lymph nodes. So that if any cancer tissue is left behind in those lymph nodes, even after the operation, this cancer can grow back. So what the doctor do is he removes all the lymph nodes from the that region which is near to the breast. So axillary lymph nodes are removed. Now these axillary lymph nodes, once they are removed, the problem is that these lymph nodes also drain the lymphatics from the upper limb. That means from the arm. From arm, all the lymphatics are drained by these lymph nodes. But since they were removed during the operation, some of the lymphatic channels they get blocked. Due to that, there is blockage, and the person after the operation, that is which operation, removal of the breast due to breast cancer, that person can have a swollen upper limb. He can have a swollen upper arm. That is due to lymphatic obstruction. Then any pressure on the lymphatics from outside can also lead to, so these on the main abdominal thoracic duct, this can occur again like gravidutrous or due to some tumor which is present in the abdominal region. If it presses on the duct, that will again lead to lymphatic obstruction. Then there is a condition called as filariasis. Now this filariasis is caused due to what due to a parasite known as Wuchereria bankrupt. Now the larvae of these parasites, they have a tendency to block the lymphatic channels, and when they block it, that lymphatic channel, too much of lymphedema occurs. Now here you see in this person, this is his normal foot, but over here, due to lymphedema, what has happened? The severe edema of the lower limb is there. This is because the Buchereria bancrofti, it has blocked the lymphatic channels in the lower limb, and so the lymph is not able, so that difference of 2 which we talked about, that is not being able to be handled by the lymphatics. The fluid keeps on accumulating, and this can cause a giant limb, which we call as elephantiasis. So this is an example of edema due to lymphatic obstruction. Then lymphatic obstruction could also be due to malignant cells. If there is any cancer in that region, the malignant cells, they can metastasize to the lymphs, and they can cause the blockage of the lymphatic. Then there is disease called as Milroy's disease or hereditary lymphedema. In this, what happens due to a child in a very young age, the lymphatic channels are not properly formed, or they do not properly communicate with each other. So the drainage of the lymphatic is compromised, and that can lead to edema. It can occur over whole of the body. So these are examples of the lymphatic obstructions. Here we have lymphatic obstruction, which lead to edema. Then tissue factors, like I told you, one factor is that certain tissues, they have got lower tissue tension because they because of the loose subcutaneous tissue is present over there. Eyelid is one example, scrotum is the another example. Then elevation of the oncotic pressure can occur due to increased vascular permeability or inadequate removal of protein by the lymphatics. In whatever reason, what is going to happen is that the proteins are going to accumulate in the interstitial region, and then the tissue will have higher protein, so it will have higher oncotic pressure, and it will be attracting the fluid more from the plasma. That is covered in the second part here. Increased capillary permeability. So what are the causes of increased capillary permeability? There could be generalized causes, or there could be localized causes causing the edema. Generalized causes include like poisoning and certain drugs. If a person is allergic to certain food or drugs, etc., and person ingests that drug, he will have edema all over the body. Then anaphylactic reactions. Some person, they are like sensitive to bee sting, etc., that would lead to anaphylactic reactions. And if they are stung by the bee, uh, or if they are exposed to certain allergic reaction, so this is a type 1 hypersensitivity reaction, IgE induced hypersensitivity reaction. Over here, the person will immediately, it's a very fast acting, and immediately the person will have edema all over the body. Then we have called a condition called as angioneurotic edema. Now it is rapid swelling in the deeper layer of the skin and mucous membrane, and it affects areas around the face like lips, tongue, cheek, even around the eye. Now here what happens, that when the person is allergic to anything, then this swelling, uh, as soon as he is exposed to that allergic uh, uh, substance, there will be swelling which can go to throat, and it can cause breathing difficulties, and angioneurotic edema can even be life threatening. So anaphylactic reactions and angioneurotic edema, these are both very life threatening conditions, and they have to be handled immediately. Then localized edema can occur during the inflammation, like insect bite. Whenever a mosquito bites it, see, you have a swelling over that area, that is a localized edema. Or use of certain irritant drugs or chemicals, sometimes new use of new jewelry or strap of the watch, that can cause swelling around the wrist or swelling near to the ear or wherever that it is used. The swelling as well as redness is there. That is an example of localized edema. So localized edema, increased capillary permeability, that causes the massive difference. That is responsible for the massive difference, and it is responsible for very fast swelling. And that's why, like I told you, that angioneurotic edema and anaphylactic reactions, which can lead to swelling, which can even cause swelling in the throat and difficulty in breathing, they are life threatening. So this increased capillary permeability is the fastest edema causing process. Then we have got sodium and water retention as a mechanism for edema. This can occur by three pathways. One mechanism is intrinsic renal mechanism, then we have got extrarenal mechanism, and we have got ADH mechanism. Now, to understand this mechanism of sodium and water retention in a body, we have to understand the normal first. See, sodium and water retention is very important for our survival, because if we are exposed in any condition where there is hypovolemia, that means where there is decreased volume of blood inside the body, the body will try its level best to preserve the remaining water inside the body. This hypovolemia, it can occur if there is some condition where, for example, there is a trauma and there is loss of blood from the body, the volume of the blood decreases, but the body will try its level best to preserve the remaining volume. It will not want that remaining volume to be lost in physiological conditions like sweating or like urine formation. So it will try its level best to preserve that volume. If the person is dehydrated because of excessive sweating, or if the person has been thirsty and has not yet been able to get the water, so the remaining water inside the body will be preserved by the body, so that mechanism will kick in. But how that mechanism kicks in? So whenever there is decreased volume in the body, that decreased volume of blood, when it reaches the heart is not able to pump sufficient amount of blood. Now that decreases the cardiac output. This decreased cardiac output is sensed by the baroreceptors, which are present in the carotid artery and the aortic arch. Now these baroreceptors, as soon as they sense that the blood which is coming, which is being pumped by the heart and which is coming to them is less in volume, they immediately cause sympathetic outflow. That means they cause release of adrenaline, etc. in the body, and that causes vasoconstriction. Now due to this vasoconstriction, the blood which reaches the kidney is decreased in amount, and then it causes what we call as renal ischemia. Renal ischemia means that the kidney will now get less amount of blood than the normal amount. So in the kidney, when this kidney gets less amount of blood, obviously it will filter less amount of blood. So that will simply cause decrease in glomerular filtration rate. So GFR, that is decreased. When less GFR is there, less glomerular filtration rate is there, what will happen? There will be less formation of urine and less excretion of sodium. This less excretion of sodium will preserve the sodium in the body. So it's a straightforward thing. There was hypovolemia. So heart decreased its cardiac output. It was sensed by the baroreceptors. Baroreceptors kicked in the sympathetic system. There was release of adrenaline, which caused vasoconstriction. Less amount of blood reached the kidney. So less amount of GFR was formed, and that led to decreased excretion of the sodium. But this is not a sufficient mechanism. There has to be, kidney has still some of the GFR which is formed. The kidney has mechanism that after that formation of the urine, it will still extract the water and sodium out of it. It will not let anything go in the urine. Now how does the kidney do that? So in the kidney there is something called as JGA. These are called as juxtaglomerular apparatus. These juxtaglomerular apparatus also sense decreased amount of oxygen which is coming, because less blood is coming, so less oxygen is there. So they sense it and they secrete something called as renin. I won't go in detail. I won't go in detail over here about this renin, angiotensin, aldosterone system. But this renin, which is released by the kidney, then it activates this angiotensinogen to angiotensin, and that causes release of aldosterone from the uh, 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 that causes release of aldosterone from the adrenal cortex. So once this aldosterone is released, this aldosterone goes and acts on the distal tubules, that distal tubule region, and it increases the sodium resorption. Then there is third mechanism, which is increased ADH. It is secreted by the posterior pituitary. So whenever there is hypovolemia, so less amount of blood reaches the posterior pituitary, and the sensors over there, there are sensors in the brain, thirst, the mechanism also thirst sensor. When due to hypovolemia, there will be increase in concentration of the blood because the volume is lost. So increased concentration, increased specific gravity of the blood will sense that something is wrong. Volume of the body is less. That will cause release of the ADH, and this released ADH, it acts on the collecting ducts and it reabsorbs the water from the collecting duct. So it simply stops formation of the urine. That's what the name is, anti-diuretic hormone. Diuresis means formation of the urine, and it is anti. So anti-diuretic, that means now the urine will not be formed much. So you see all these mechanisms, what they have done is that they will simply stop the loss of water and sodium in the urine. And this loss of water in the sodium and urine, it will be retained in the body. Now this is a good thing. This is a good thing because hypovolemia occurred and our volume has to be preserved. But what if the kidney is fooled? If the volume in the body is sufficient, but the one reaching the kidney is not enough, the kidney will think that there is less volume of blood in the body, and kidney will start doing all this exercise. So less urine will be formed and kidney will increase. So more sodium and more water will be preserved, and added to the normal volume, it will cause hypervolemia. Now that would increase what? The hydrostatic pressure, because more volume. Now the kidney is stopping the formation of the urine. Kidney is preserving the volume and adding it to the normal volume and causing increase, too much increase in the volume. When that happens, it will lead to edema. So this occurs whenever there is renal ischemia, by mechanism other than the hypovolemia. The volume in the body is normal, but there is renal ischemia, and that leads to increased renal tension of sodium and water, causing edema. So what are these conditions? So these conditions are congestive cardiac failure or renal failure. In congestive cardiac failure, what happens? Left heart has failed. It is not able to pump out sufficient cardiac output, although in the blood the volume is sufficient, but since the heart is not able to pump it, the kidney senses that the volume is less and it does everything to cause edema. Same way, the renal failure, renal artery stenosis, or sufficient amount of blood is not reaching the kidney, or due to any reason, what will happen? Kidney will not be able to form sufficient amount of urine. There will not be excretion of water and sodium in the urine. It will start accumulating in the body, and too much of fluid will accumulate in the body. That will increase the hydrostatic pressure in the tissue, which will lead to the edema. So that finishes with all the mechanisms and pathological pathways of edema. We have covered all of them. Now let's recapitulate all of them. So we discussed 6 various mechanisms by which edema can occur in the body. The first one being decreased plasma oncotic pressure. That includes nephrotic syndrome, nephritic syndrome, liver cirrhosis, malnutrition, protein losing enteropathy. So here the important thing to remember is that any condition in which protein is either lost from the body, which could be because of the renal causes, or it could be because of the enteric causes, or where the protein intake in the body is very low, like malnutrition due to kwashiorkor, or where protein is not synthesized in the body because of the liver cirrhosis, that would lead to decreased protein in the body, in the blood, and it will cause decreased plasma oncotic pressure, which is responsible for edema. Then the second word, increased capillary hydrostatic pressure. Over here, any condition which will increase the hydrostatic pressure in the capillaries. And the important one was the venous blockade or decreased cardiac output. Here in the congestive cardiac failure or constrictive pericarditis, there is back pressure in the arteries, in the veins, which are bringing the blood to the heart, and that back pressure is then further reflected into the tissue behind it. So pulmonary veins, which are bringing blood in the right atrium of the heart, the pressure increases and that pressure is reflected in the lungs, so that would lead to pleural edema. Then portal hypertension will cause ascites, venous thrombosis, and postural edema. These are responsible for edema in the various parts of the body where there is increased hydrostatic pressure due to increased gravity, causing increased pressure. Lymphatic obstruction, important among them was mastectomy. After mastectomy, if we remove the axillary lymph nodes, that will cause edema in the upper arm. Then pressure on the lymphatic duct in the abdomen due to some tumor or due to gravid uterus, filariasis due to Wuchereria buncrafti, malignant invasion, and Mendelois disease. They were responsible for lymphatic obstructions. Tissue factors, periorbital edema and inflammatory edema was the example. Inflammatory edema, it could be generalized or it could be uh, localized. Then increased capillary permeability. Now this one is important. This is what we as a pathology are commonly encounter. It is allergic reaction due to poison or drugs, and neurotic edema. Localized could be insect bite like mosquito bite, etc., or any irritant chemical. This type of edema is the edema which is most commonly encountered in pathology practice during the inflammation. And then we had sodium and water retention, which could be due to cardiac failure or due to renal failure. So here we have all the types of edema. You can take a screenshot of this slide, and you will have a ready reckoner due to with the examples and everything. If you get a short note, you can simply mention these types of edema at the end of your answer. I hope you found this lecture interesting as well as informative, and it added to your knowledge. If you have any queries, please feel free to comment them in the comment box. Thank you, everyone.